Hi, we are going to discuss another chronic myeloproliferative neoplasm, which is essential thrombocythemia. Essential thrombocythemia involves primarily the megakaryocytic lineage. It is characterized by sustained thrombocytosis in blood along with increased number of large mature megakaryocytes in bone marrow. And clinically there may be occurrence of some thrombosis, hemorrhages as well. Presence of BCR-ABL1 gene fusion rules out essential thrombocythemia. It usually occurs in the older age group, 50 to 60 years of old. There is slight female preponderance. It can have a second peak in 30 years old. It can occur in children as well. Etiology is not known, but genetic mutations of JAK2 and galsoline have been associated. Major site of involvement is almost always blood and bone marrow. Extramedullary hematopoiesis can occur in later stages. Spleen is not a site for extramedullary hematopoiesis in essential thrombocythemia, but it is a sequestration site for platelets. 50% of patients almost always are asymptomatic and are discovered incidentally. The rest of them present with manifestations of vascular occlusion or hemorrhages. They can be microvascular occlusions causing TIAs, paresthesias. Major arteries and veins can also have thrombosis in them. ET can be a cause of splenic or hepatic vein thrombosis in Budd-Chiari syndrome. Bleeding can occur from mucosal surfaces such as GIT. Platelet count is increased more than 4.5 lakhs per micron liter. Bone marrow biopsy in these patients is especially helpful for us to rule out other myeloproliferative neoplasms, which are associated with high platelet counts. Coming to the microscopy on blood, there is normocytic, normochromic RBCs, WBC, and their DLC is normal. The major abnormality lies within platelets. There is marked thrombocytosis, that is increased in platelet counts, and these plates also show variation in size from tiny forms to atypical large or giant platelets. Leukoerythroblastic picture and teardrop RBCs are not seen in ET. Now coming to the bone marrow picture, it is usually has normal cellularity. Rarely it can be hypercellular. The most striking abnormality lies within the megakaryocytic lineage. There is marked proliferation of megakaryocytes with the predominance of large to giant forms with abundant cytoplasm. These nuclei can be hypersegmented staghorn nuclei. These increased megakaryocytes are usually spread out throughout the bone marrow in loose clusters. These are atypical megakaryocytes which were seen in early pre-PMF, early pre-fibrotic PMF are not seen in ET. Erythroid proliferation may be seen, but granulocytic proliferation is usually not there. There is no increase of blast, there is no dysplasia in granulocytic lineage. The network of reticulin fibers is usually normal or maybe increased to grade 1, never more than that, because significant reticulin fibrosis excludes ET. Now coming to the diagnostic criteria of essential thrombocythemia. Now let's discuss the 4 major criteria for essential thrombocythemia. The first is platelet count has to be increased or more than equal to 4.5 lakhs per micron liter. Second major criteria is megakaryocytic lineage proliferation in bone marrow biopsy with increased number of mature hypersegmented hyperlobated nuclei. Third is WHO criteria of BCR-ABL CML, PV or PMF are not met. The fourth criteria is JAK2 calretinine or MPL mutation. The minor criteria is presence of any clonal marker. The second minor criteria, absence of evidence of reactive thrombocytosis. As we know that the platelet count can be increased in reactive conditions as well, so you have to rule out those conditions. Now, DDs are very important in essential thrombocythemia as the characteristic histologic features in the bone marrow of ET can help it to distinguish from other causes of increased platelet counts. Megakaryocytic size is usually large or giant in ET, whereas it is variable in pre-PMF. In ET, the nuclei of these megakaryocytes are staghorn, hyperlobated, hypersegmented, whereas in pre-PMF they are bulbous or hypolobated or cloudy or balloon-like. Reticulin fibrosis is very rare in ET and it is very frequent in pre-PMF. So the second differential is polycythemia vera, but that one usually has erythroid proliferation and granulocytic proliferation associated with it as well. The myelodysplastic neoplasm will show significant dysgranulopoiesis or dyserythropoiesis. MDS with isolated 5q deletion, even though it has only megakaryocytic proliferation, it will have medium non-lobated megakaryocytes. They are not giant or hyperlobated like in ET. The megakaryocytes are small and dysplastic in AML or MDS with inversions. Sometimes CML can present with isolated thrombocytosis with leukocytosis occurring in later stages. In these cases, BCR-ABL positivity is the only way to rule it out.